Hey everybody, hope you are having a wonderful day. Welcome back to another episode of Digital Health Entrepreneurship. I'm sitting here with Laurence, Girard, and Drew Kaiser. And today we're going to talk again more about the inside workings of Fruit Street, but also really how telemedicine works on a practical level. So Drew, thanks so much for sitting down with us today.
Of course, my pleasure.
Awesome. Drew, why don't you start off just by kind of giving us some insight into what your role is there at Fruit Street, and then Laurence has some great questions lined up for you.
Yeah, so a little bit of my background. I'm traditionally emergency medicine trained, so I'm board certified in emergency medicine, and I've been doing quite a bit of telemedicine over the past year. I got involved, I would say, with Fruit Street initially as a physician investor. But I worked with some other telemedicine startups as far as development of their user interface for physicians, because I think that's one thing that's always lacking in EMR, any EMR system, is how is the ease of use for the physician when you look at a certain system. And so I started talking to Laurence about ideas that I had, feedback I had, and over the next couple of months, that kind of led into assuming a role of medical director. So not only developing the user interface and working with the engineers, but also now creating a lot of our clinical guidelines, scope of practice for COVID MD, and then where we will potentially be going in the future.
So yeah, thanks for that background. So I guess could you share with everyone, how many telemedicine consultations you think you've done in your life, and what would you estimate?
So there's a combination of telemedicine is broken up into two categories: asynchronous and synchronous. So synchronous is a face-to-face conversation that you have with a patient, and there are a lot of telemedicine platforms that will support that. But there are also asynchronous consultations where you're able to communicate to the patient either back and forth via text, or to do chart review or medication reviews. So between asynchronous and synchronous, it's got to be close to 13,000 consults I've done. I'm losing track, but yeah, it's well over 10,000 at this point.
That's incredible.
Yeah, on that asynchronous versus asynchronous, I've been investigating that recently. I mean, have you ever done any calls for 98.6 or
Mm-mm.
So 98.6 is like a text-based primary care, so there's no
Right.
video call. I think you can only do that in certain states, though. Do you know?
Yeah, so different states have different regulations on what they consider to be an encounter with a physician. And I can't speak to each state, but there are differences on what, within certain state regulations, on what they consider to be an acceptable encounter. Some states will allow for text messaging or asynchronous encounters. I live in California. I do it in California, Texas, Florida, New York. I know I've done those in the past. But I do know that other states are far more strict on what they consider to be an acceptable encounter that either has to be a audio or a video synchronous encounter. So there are, and those regulations are changing. I think they're going to keep changing over the next couple of years as telemedicine improves.
Does it concern you at all, text messaging with a patient that you can't necessarily verify their identity? I mean, I would imagine that it depends on what they're asking you to prescribe or what their condition is, right? I mean, because I could imagine that maybe for some things you might not want to do it over text, but if it was over video, maybe it'd be okay. I mean, I just feel like if I was a physician, maybe I would be a little more hesitant for certain things through text messaging. I mean, sure, if somebody wants like an antifungal medication prescribed, like, okay, that's one thing, but then there's other medication where maybe it's more serious, if you know what I mean?
Yeah, and so there are certain restrictions as far as those asynchronous encounters, and a lot of those do tend to be medication refills or renewals. So like if I'm going to refill somebody's statin, and they can just take a picture of their labs and upload that for me, and a picture of their ID and a selfie of their face, and I can confirm who the patient is, I can review their labs and what medication they've been on, and I can very easily renew their current statin medication, something like that. That's very simple. That's something that is completely appropriate via an asynchronous encounter. It saves them a trip to the physician's office or trying to communicate with their personal physician, and they can just have it done very easily from their home. But it does become, a little bit more difficult when they're trying to describe, their sore throat or a rash or another thing where you need to be able to at least lay eyes on the problem. So there are certain confines regarding, what you can and can't do with asynchronous, but it does end up being a huge time saver for patients and a big convenience when you can do a lot of those very simple things.
Mm-hmm. Yeah. And another question I have is your experience with physician staffing models for telemedicine. Because I think that's one of the hardest parts is as a telemedicine company, it's a supply and demand issue of how many patients and how many doctors. You don't want the doctors just sitting around all day waiting for consultations if the telemedicine company is only willing to pay them on a per consultation basis. And the telemedicine company doesn't want to pay them hourly to just sit there and not earn any revenue. So I guess what have you seen is the most common staffing model? Like, do physicians sign up for a shift, or do they get a text message when there's a patient, or what have you seen?
Oh, it's all over the place. It's all over the place. And I think that's one of the, in any type of emerging market like this, I think that's one of the biggest initial hurdles is trying to maximize the time for the physician so that they don't feel like they're wasting their time and they could be doing something more profitable. But also making sure you have appropriate availability for a patient so that patients are going to continue to use your platform. I've seen mix. I've seen combo of we'll pay you a very small hourly rate with a per consult fee on top of that. Some are purely per consult fee, and those are harder to allot certain time frames. You could sit there for 8 hours and get 6 consults, and then if you haven't done anything else with your day, that's kind of, you've wasted a lot of time as a physician. That's not worth your time. And so with those models, I think it's very helpful where if a physician could just say, yeah, I'm available this day, I'll be going about my day-to-day business, doing what I need to do. But if you send me a text message when the patient is ready and I can go to a place where it's private and I can have an encounter that's HIPAA compliant, then that ends up being the best of both worlds because the physician can be doing whatever else they need to do if they're just at home. And then you notify them. So I've had good success with that model as well, where I just get a text message notification, here's the next 5 minutes, the patient will be ready for you. That's another benefit too of asynchronous is you can respond on your own time. But like I said, there are some limitations with that as well.
What have you seen is the range of what telemedicine companies will pay per consult for these, simple internal medicine visits?
For a synchronous consult, they tend to range anywhere from 20 to 23 up to 30 to 40, sometimes even $50, depending on weekday versus weekend, day and night. So a lot of companies do offer a differential where if you start taking consultations at nighttime, because they want to offer 24-hour coverage like any urgent care or ER would. But there has to be an incentive a lot of times for the physicians to take consults in the middle of the night when patients might need them. So there is a wide range. I do know that companies do have a little bit of flexibility as far as negotiations go with that. But I would say the basic anywhere from low 20s to $30 range for a general synchronous consultation, Monday through Friday is pretty much a good estimate.
Do you have any recollection of these, what the hourly rate has been for these models where it's like a base hourly rate plus a per consult fee?
Yeah, so that also varies state by state too, because different states have different regulations on whether or not you can have a nurse practitioner or a physician as the provider. And so that tends to vary quite often. So I've seen, I'm just constantly getting, through different job websites, ranges from what companies pay. And that tends to be anywhere from they'll say $50 to $125, and maybe 50 is the base rate per hour, 50 to 75 per hour. And then plus a per consult fee, maybe you can flex that up to over $100, 120, 150 per hour, but it varies so much that it's really, it tends to be very dependent on the company, and companies might be changing very quickly.
Yeah, that's interesting. I haven't thought about that model before because I mean, if a telemedicine company were to pay a physician $50 an hour for 40 hours of coverage a week, it's $2,000, which is really not that much. But then, if the physician were to do, I don't know, let's just call it 100 consults in a week, I mean, they could be earning $4,000 a week.
Mm-hmm.
I mean, they could end up earning, $15,000-$20,000 a month in
Right.
theory, if the volume's there. But I think that's, I almost feel like for a new telemedicine company, paying some base hourly rate plus per consult is probably the best model, because otherwise, how are you going to have physicians available? I
Right.
mean, do you agree? I don't know.
And another thing as well is the landscape is changing, and it has been changing drastically over the past couple of years. So as I've been watching these job offers come in, initially it was, we need coverage in Texas, we need coverage in California. California, Texas, New York, Florida, a couple other states tend to be some of the more telemedicine heavy states. And so they would say, we need coverage in these states. And now over the past year, I would see we need a physician with a minimum of 5 state licenses, and now a minimum of 10 state licenses. I saw one job that was posted, minimum of 20 state licenses. And so there's this market that's being created for physicians that if you can get a lot of state licenses, you can market yourself very well for these telemedicine companies. And it benefits both. You can fill your plate with now consults from multiple states at once, and that company can guarantee coverage in all of those states with just 1 or 2 physicians.
Yeah.
And so I'm seeing the landscape change as far as that goes as well.
Yeah, and also I think there's the Interstate Medical Licensure Compact.
Yeah.
Are you familiar with that? I think it expanded to like 32 states, where if you have one license in one of the states, you can get coverage in the other ones fairly easily.
Yeah, a colleague of mine just did that. So he's in, so there are certain states where it does not apply. And unfortunately, the last time I checked, where I live in California, that is not an eligible state. But that is a very valuable thing for somebody who is eligible, who does live in one of those states, where you can very easily obtain many state licenses at once. A friend of mine is actually doing that. And I'm, different states, it varies. You get a licensing company that can help you, but can still take many months to get a state license. And a friend of mine just started a couple of weeks ago and had 10 state licenses within 2 or 3 weeks, just like that.
Yeah, so it looks like California, Texas, Florida, New York don't have it yet.
Right.
So it looks like if a physician had a license in California, New York, Florida, Texas, and let's say, Illinois, it looks like they would be covered in, really in the majority of the country. I need to check on this in more detail, but is that your understanding? If you have a license in any one of these blue states, you're covered in the rest of them, or do you have to apply for another license for the compact as well?
I believe it's where you're physically located. So you have to be based in one of those states, I think, is because it would have been easy for me to just get one of those state licenses and then be eligible. But I think it's based on where you are located. You like either your home address or your home state.
I'm not sure. I thought it was per license, but it's on my to-do list to check with the lawyers. That would be it would be easier, because then you would just ask yourself, which state is the easiest to get a license in that's done.
Right. Exactly.
But anyway, we should check on that. But yeah, because the licensing companies definitely charge quite a bit, like several $100s per physician, when they want to charge us.
I'm curious, Drew, are most doctors that are doing telemedicine, is it like something they're doing on the side, or how many percent, like, what do you think the percentage of doctors, or are there any that, they're truly just, their whole job is taking telemedicine visits, and they're kind of, connected to a few different companies that could be sending them patients, and they're, sitting at home or sitting in their office, kind of just taking a high volume of consults each day?
So the vast majority of physicians have zero experience with telemedicine at all. So that is going to be something that continually changes over, let's say, the next decade. I think it's going to be, and COVID has kind of forced our hand in that direction,
Right.
you know. So more physicians now are being forced through their hospital system or through their organization to take telemedicine consultations that they've never done before. And it's showing this market and the validity of it, I think. There is a very small subset of physicians who do this full-time. They get, 20, 25, 30. Some physicians have 50 state licenses. They're just licensed in every state, which it seems like in and of itself would be a full-time job just managing those licenses.
Right.
And they're just with a couple of companies, and some physicians will just full-time, they can make what they made or competitive to what they would make full-time working in a hospital or in a clinic, just sitting at their home and doing telemedicine consults. A friend of a friend, he had said at one point, it's like, I do not want to touch another patient in my career. That was like his joke. And so he just went full-time with telemedicine and is making pretty much the equivalent salary that he would as a hospitalist before he transitioned to telemedicine. So it's certainly a possibility.
I mean, if you did 10,000 consults a year at $30, it's, $300,000 a year, which would be like 200 consults a week, which would be like, what is that? It's going to be like, I don't know if you could do 40 per day. I guess it's not.
Yeah. And I mean, these aren't like hour-long Zoom calls with patients. Like what's the usual length of some of these calls with patients?
Well, you do get feedback from these companies. So one of the companies I was with, the average call would be about 11 minutes.
Okay.
Yeah.
Which isn't that abnormal from when you go into a family practice doctor once you're checked in and everything. I mean, it seems pretty equal to the amount of time you're spending with a doc.
Right. Oftentimes they'll carve out 15 minutes for a follow-up visit in the clinic. They're trying to get patients in and out as fast as they can. And that's also different with synchronous versus asynchronous consults. If I'm doing a synchronous encounter, I have to make sure that I can see a patient, talk to them. We have a more formal encounter, so to speak, and that can be, 11 to 15 minutes or so. But asynchronous consults, sometimes, you can do, 1 in 2 to 5 minutes, depending on what type of renewal you're doing for like a medication or something like that. Someone needs to new birth control medication and they've been on it and they've been seeing their primary doctor. I want to get it from you so I don't have to go into clinic. That doesn't take a lot of time. You're not going to be reimbursed $30 for that. Those tend to be, in the sub $10 range. But when you're talking about 2 minutes worth to do a consult, again, if you get that volume up, then it can certainly add up to quite a bit.
Yeah. And I guess, like, what are the most common conditions that you see being treated through just a video visit with a physician, leaving aside all the other things that Fruit Street does, but just in terms of like internal medicine consults?
Yeah. What the bread and butter are kind of the low risk urgent care. And that's kind of what we're developing as far as Fruit Street's initial model. It's the general musculoskeletal complaints, the cough, cold, URI, flu, now COVID as well, as in with all of that, bronchitis, rash, simple, uncomplicated urinary tract infections, things like that, basic fungal infections, a tinea type infection. Those are kind of the bread and butter, and those make up the majority of what I've seen kind of across all platforms.
Could you describe a situation where you feel like it's borderline, where maybe you ask 50% of doctors if they, if you should treat this through telemedicine, 50% say yes, 50% say no? What are those like borderline ones where you feel a little bit uncomfortable?
That's constantly changing. There's, things like, a urinary tract infection in a female, much more common to have a very simple, uncomplicated urinary tract infection. Then you have a male, and then you think, okay, UTIs are much less common in males. What are the chances that this could be a sexually transmitted infection? And is this something that is appropriate to treat via telemedicine, or should they go and get a formal test and know exactly what it is that they're dealing with? And that's what I always tell physicians is, at the end of the day, even though this is very ease of access, this is still decisions that you're making under your medical license. And so you need to be comfortable with the care that you provide. And I think it's important for companies to also continue to provide recommendations. That's part of what we're developing with Fruit Street right now, is the scope of practice for our physicians. When, as a company, do we feel like, in general, there are just too many red flags associated with this, and we need to refer the patient for an in-person evaluation?
Right. What do physicians like the most about telemedicine in terms of working for these companies, and what do they like the least? Like, what are their biggest complaints?
I kind of sum that up with people in that you have infinite flexibility and no reliability, I guess. And that's kind of the very general term to say you can set your hours as much or as little as you want, whatever availability you want. There tends to be very lax non-compete with a lot of these companies as well. As long as you provide service for them and you want to take on roles with other companies, then that tends to be favored. But it's the market of telemedicine, and you are just waiting for those consults to come in. So you're hoping that the company is continuing to bring on new patients to advertise, whether it's business to business or business to direct to consumer. I had one company that just changed their advertising model, and I dropped to a fifth of the volume that I was doing from 1 month to another, just because they said, we're not going to advertise to this patient population anymore. We're going to work on some back end stuff. And then it affected me directly by losing a huge volume of patients. And so that's the give and take of it, for sure.
Yeah. And I was just curious, I mean, from your experience, have you witnessed a lot of patients that are paying out of pocket for these visits? I'm not sure if you would even know. I mean, certainly there's a lot of employers and health plans that cover this as a benefit, but like, are you ever made aware of the fact that patients paying out of pocket, or do you think there's, I guess the question is, do you think there's an opportunity there for patients to pay directly, or do you think that most of it really has to go through employers and health plans covering it?
I think when you're looking at urgent care models, there's a huge benefit for those to be offered with an employer's health plan, and it's very convenient to say to a patient, if it's just something very quick and you don't, it's the middle of the night and you've got really bad earache and you've had ear infections in the past and you don't want to go to urgent care and you want to talk to a doctor and see if a doctor can evaluate it via telemedicine, that's a big offer to employees of a company. And it's a big offer for a telemedicine company to show an employer how much money they could save by incorporating a model like this. But so with that being said, when you see the patient, oftentimes you do not have to worry about the billing. That's another huge benefit as the provider. You're getting a flat rate a lot of times for these consultations with these companies. And so you oftentimes don't see if it's self-pay or if it's a part of a health plan. Mm-hmm. A huge part of telemedicine as well are a lot of the lifestyle medicines. We see all of these commercials for, erectile dysfunction medications and all of this stuff. And I believe a lot of that tends to be self-pay because that's where patients are more comfortable just, not having that uncomfortable conversation face-to-face with a doctor. They'd rather have that via telemedicine. But that's a huge market for telemedicine as well.
Right. Makes sense. And I guess what do you hear from doctors in terms of their overall feedback on the quality of the user interface in the actual software of these other companies? Like, are they horrible across the board? Amazing? I mean,
that's what's hard, is because you are limited by the audio visual capabilities of the patient. Oftentimes you can have this amazing setup. You can have great audio. You can have a webcam. You can have well lit. I've got my light right here. And so the patients can oftentimes see you, and then you are just getting a 4-pixel choppy audio encounter with the patient. And that is very frustrating, especially when, it's something where you need at least a visual encounter where, I need to be able to see this rash. I need to be able to see, the back of your throat, if you can even show it to me on a webcam. And that's one thing that tends to be helpful with that is to allow for the patient to upload photographs at least separate from the encounter, so that you at least have some evidence of what's going on. But that's one of the biggest frustrations for me, is simply the technical limitations of, a patient who doesn't have good coverage wherever they are in a completely different state from me, trying to troubleshoot on the fly with,
So I guess you would say that having the option to talk on the phone as a backup would be important.
I do that sometimes. There are some times where I'll use the video visit as a simply to know that I can identify the patient that I'm speaking to, the patient I should be speaking with. I can get a visual of them. Can you confirm your date of birth with me? Or depending on the platform, can you confirm that with a photo ID? And then at some point, if you determine that, all right, I don't need any more of a video capability with this, we can just convert to an audio only encounter. And that's a very helpful thing to offer as a backup as well.
Mhm. Yeah, it makes sense.
Mm-hmm.
It's
And then
really interesting. I mean, it's changing. I'm sure that it's changing the way that doctors even like approach retirement, because doctors are one profession where they just like working. And I've known a lot of doctors that once they approach retirement, some want to just be done, but some would like the idea of continuing to be able to, do stuff here and there. So I think it's going to be really fascinating over the next couple of years just to see how this changes the game of employment for physicians and how they interact with it.
yeah, and I guess another question would be, how often do you think these telemedicine companies will require a physician to work a minimum amount of hours per week? Because one problem that I see happening is the following. I mean, I'll tell investors, well, what if we had 300 doctors doing one consultation per day? Well, it'd be 100,000 consults in a year, which might be $7 million in revenue. Yeah, I don't mean that literally, because I mean, one consultation per day is great, but if you ask me, like, what would I rather have, 300 doctors doing one call per day or 100 doctors doing 3 calls per day? I mean, you would think that the competency of the physician in terms of their skill in doing telemedicine would be greater if they're doing more consults. So I guess, like, how often do you see telemedicine companies requiring a minimum number of hours, and what does it usually look like? Is it 5, 10 hours a week?
There are certain differences with companies. Some companies, they rely on what I kind of call it is like a playing in the sandbox model, where as soon as you see something open up, you just reach out and grab it and you take it. And with a company like that, as long as you can get the volume of physicians, then those companies don't really need to worry about you providing a certain set amount of time, because they can have thousands and thousands of doctors that are just, and you pretty much guarantee that, okay, at any given time, we'll probably have doctors that will provide enough coverage. And if you don't, and you start seeing consults back up, then you can start sending little reminders to physicians, or little additional incentives, for the next 30 minutes, kind of like how Uber has their flex rates, where if it's very busy, you pay a little bit more for Uber. But others do certainly ask for you to carve out like a 4 or 6 hour window that you can dedicate, and then you can set your schedule based on your week, which some physicians prefer that, because if they're planning, their week in clinic, like a friend of mine, he, Thursdays are his day off in clinic. And so Thursday, if he can, he would like to carve out a set amount of time and have patients be able to schedule with him for telemedicine consults, or he can just take urgent care consults on like a walk-in, basis for that set time as well. So that's another thing that varies across the board. And with all these different companies, there are different models that physicians can tend to find one that works well with their personal schedule.
I mean, I would think that from the physician's perspective, they probably just like the per hour model plus a per consult fee the most, because I could see a physician just getting frustrated with, like, fighting over consults, like, oh, I didn't grab it fast enough, right? I mean, do you think that's true?
It is, yeah. And there are different models where some will just have the consults available and you just grab what's next in line. And, during cold and flu season, yeah, there might be, 50 consults waiting. And so you just keep taking the next one. What COVID has kind of created is this huge market. And so now so many more physicians are signing up for telemedicine, that we're in this interesting transition phase where we have a huge interest in it, but companies are still trying to catch up with all of the physicians that are showing this much interest in providing the patient volume. Physicians kind of realize that the good old brick and mortar of encountering patients during a global pandemic puts their livelihood at risk, when if you have your own clinic, how am I going to keep the doors open if I can't keep getting patients in? So a lot of these physicians then transition to, at least as a supplemental income, telemedicine. So there's a huge influx of physicians. Now, after the pandemic, it'll be interesting to see where that kind of settles out as far as supply and demand, so to speak. But for me, I try to just give availability for certain blocks of time. I'm not with any company that gives a base hourly rate at this point.
It's probably rare.
What's that?
I would imagine that would be a rare model.
Yeah. A lot of the companies like to do a per consult, just a flat per consult rate. We call it like it's kind of crude, the eat what you kill model, which is not in medicine. You can edit that out. That's not appropriate for a medical podcast.
Rarely it is, but anyway. Yeah. So another question was, so I was just curious. I mean, I know you're an emergency medicine physician, but in your view, what percentage of primary care do you think could be done through telemedicine? Because I've seen some of these companies where they're offering consumers a subscription for $160 a year, basically unlimited calls with a doctor. And I think it probably depends on the patient, right? I mean, if you have type 2 diabetes, you have, foot ulcers, whatever. Okay, that's one thing where I could see why you would need a physical exam. But, if you're someone that's relatively healthy, I would imagine that, a physician talking to you, writing prescriptions that you can pick up, that also had the ability to order labs. So say if I have to go to Quest and get an A1C done, isn't the majority of primary care, talking to a doctor, getting prescriptions, getting lab tests? I'm being provocative intentionally, but how much of it could really be done through telemedicine for that person that's just, relatively healthy?
I think much more than we currently give telemedicine credit. I've been talking to a lot of friends about that because that's something that I'm very interested in as well. In the emergency medicine, it's a very different environment. It's very hands-on. I'm doing a lot of procedures. Patients come to me because, it's kind of more of an extreme situation. But in clinic, I've been talking to a lot of my friends who are primary care docs who work in the clinic, and I ask them, how many encounters do you actually need to lay hands on a patient versus how many are you just doing, you're going over lab results and you're making changes to medications. Even you had mentioned wound care. That's a huge area for telemedicine where you can have an initial consultation with somebody, provide a little bit of a wound care guideline. And then for follow-up, how much of that needs to be in person versus how much of that can just be really good photographic evidence of how that wound is healing. And so there's so much that, one of the sayings in medicine is through a good history and review of systems, you should be 90% of where you need to be to make your diagnosis anyways. In your physical exam, it's just that last 10%. Mm-hmm. And so how much of that 10% now can we do via telemedicine versus how much of that 10% needs to happen face-to-face? That's where I'm excited to see where, we change the future of healthcare with telemedicine, because I think it's going to continue to grow.
Yeah. I heard there was a survey that was done recently. It was something like 25% of patients were definitely willing to get rid of their primary care doctor to have a virtual one. And there was another 25% that said they would, consider it. So we're basically at 50% of people that would consider having their primary care doctor be a telemedicine physician that they don't necessarily see in person. There's also a huge percentage of the population that doesn't even have a primary care doctor.
Right.
When I look at these services that are basically saying you can have a doctor for $160 a year, I don't know. It seems compelling if you don't have insurance, you don't have a primary care doctor. But
it's super compelling.
It's very compelling, and I think it's where we'll end up with is the pendulum will sway back and forth until we kind of find the groove of where telemedicine fits really well. We don't want to risk missing something. Somebody has a murmur. I'm not going to be able to hear that murmur unless I put a stethoscope on their chest. That still has to be a face-to-face interaction. Patients also really value being able to see a physician over time. My wife, she's a pediatrician. The greatest love that she has for her job is getting to see somebody from birth through their entire childhood. And so she loves that continuity of care. And you don't want to lose that. You don't want to lose that sense of being able to tell your physician what you wouldn't even tell your closest family members because you confide in your physician. And so we need to make sure that as telemedicine continues to expand, we can still offer that level of care for patients and know when it's appropriate for them to have a telemedicine encounter and when it's appropriate for them to be seen in person. And, you know, that's just the frontier of any new aspect of, you know, whether it's healthcare or another type of business. You know, we're just going to find those boundaries within reason, and it'll be an exciting next couple of decades. I certainly think so.
Yeah. I think you said it well. It's going to be a little bit like a pendulum where we're probably going to realize, oh, we could have been doing this all along with telemedicine. Yeah. And there's probably going to be a little bit going the opposite direction where we realize, oh, maybe we should pull back and keep that only for primary care. But this is fascinating. And like you said, the next couple decades, I think it's going to change the workplace for doctors, but also just transforming how we even think about interacting with medicine. So Drew, thanks for sharing some of your insight, and we'll have to have you back on the show in a couple months to talk about how things have changed.
Yeah, I'd be happy to. And things are changing very rapidly at Fruit Street as well. So I'm sure we'll have quite a few updates. Laurence needs to maybe get to work a little bit. But
yeah, come on, Laurence.
Come on, Laurence. Pick up the pace. There's only 24 hours in a day, man. You need to squeeze out maybe 26 or 28.
That's more state licenses.
Yeah. Gosh, I tell you, that's, yeah. Once we improve that and people can get state licenses much more easily, then we'll see telemedicine explode. For sure.
Definitely. That's cool. Well, thanks so much, Drew. Thanks, Laurence. And we'll see you next time.
All right. Thanks, everyone.